Hello. Hello, can you hear me? Can you all hear me?
Yes, ma'am.
A second, please. Okay, then we shall start. Okay.
Yes, ma'am.
Okay, the topic today is endometriosis. Now this topic is very, very important, not only for your exams, because every year in the university or in the averages, this question is asked. It is of immense clinical importance as well as it's an important clinical scenario. Okay, so this endometriosis has got very clinical application as well as for your yearly exams also. It will be frequently asked. So you have to know what it is, and you have to mostly it is an essay or it's a short essay like question. Sometimes, rarely, a 2-mark question will be asked about the medical management of endometriosis or the surgical management like that. But frequently it is asked as essay. Okay, so you should know what it is and you should prepare it. Now, what is this endometriosis? So it is not the presence, you should not say it is the presence of endometrium. It is not the presence of endometrium. It is the presence of endometrial glands as well as stroma, which is outside the uterine cavity. So the endometrium is destined to line only the uterine cavity. So when the presence of endometrial glands and stroma occurs anywhere outside the uterine cavity, it is called as an endometriosis. You know the other entity, when it occurs in between the muscle layers, you call it as an adenomyosis. So this is when it occurs in the pelvic peritoneum or elsewhere, it is called as endometriosis. Now, what is the pathology here? The first slide, please. So it produces a chronic inflammatory type of a reaction. Okay, so that is the importance of it. It produces a chronic inflammatory reaction. So when inflammation occurs and when it subsides, it leaves behind adhesions, altered anatomy, all those things, and the sequelae of those things. That is the actual pathology which is happening. It affects about 6 to 10% of the women of the reproductive age group. So endometriosis is the presence of endometrial glands as well as stroma outside the uterine cavity, which produces a chronic inflammatory reaction, and it affects about 6 to 10% of the women of the reproductive age group. Now, what is the pathogenesis? So this is a disease of so many theories. So exactly we do not know what is the cause, but you can see pelvic endometriosis as well as extra pelvic endometriosis. So it is not the same way by which it is occurring in the pelvic cavity or it is seen elsewhere. So many theories have been postulated in the origin of endometriosis, and hence the origin is multifactorial. You have so many names also associated with it. And one is the Sampson's retrograde menstruation theory. So when a retrograde menstruation occurs, so that is an occurrence. It happens during periods. And when you, in certain cases of abruption, when you open up the peritoneum, you can find the blood oozing through the tube into the peritoneal cavity. So reflux menstruation or reflux loss of blood into the peritoneal cavity through the tubes is a natural occurrence. So this happens during periods also. So when such an endometrial viable endometrium gets implanted into the pelvic cavity, and further vascularity is retained and it goes there, producing endometriosis. So that is Sampson postulated this theory. Then another person called as Mayer, he postulated that it is due to the metaplasia. So in the peritoneum, you can find multipotent cells. So the cells have the capacity to change into any type of epithelium. So the multipotent cells, Mayer postulated that it is not the retrograde menstruation, but the multipotent cells of the peritoneum undergoes metaplasia, and they develop into the endometrial cells, and they give rise to the endometriosis. Now the third slide, please. Now another theory is the vascular dissemination. Vascular dissemination theory. So you can find the endometriosis in other sites like the lungs, in the bladder, rectum, etc. So what is the cause of this? So a direct implantation does not occur. So here it is postulated that the endometrial cells enter the uterine vasculature and are carried through the vasculature to the different parts of the body like the lungs, bladder, kidney, etc. Then there is also another theory called as direct transplantation theory. Okay, so this explains the scar endometriosis, or following a cesarean section after 6 months, 8 months. Certain patients come after 1.5 years saying that they have a painful swelling there. The pain increases premenstrually at the time of periods, and there is a swelling they can palpate there. So that is called as a scar endometriosis. Now, how does this occur? It is thought that it is due to the direct transplantation of the endometrial cells, especially following the cesarean section. So that is the major theories behind the origin of the endometriosis. Then certain genetic factors also play a role in the formation of endometriosis, because it is seen that it is 6 to 7 times prevalent in the first degree relatives. So usually sisters, cousin sisters, first cousins, all those people tend to have endometriosis, or it runs in families. So there is also thought to be a genetic factor behind the occurrence of endometriosis. Then there is also a role of environmental factors. Cosmetics, toxic chemicals, etc. can also induce endometriosis. Okay, and it is more seen in people with chances of ectopy, that is allergic tendency. It is more seen in such people. So these are the theories behind the origin of the endometriosis. So Sampson's retrograde, Mayer's metaplastic theory, then the direct implant, then the vascular dissemination theory. So that explains ectopic sites like lungs, kidney, etc. Then there is direct transplantation theory that explains endometriosis in the scar site. Then genetic theory, so it runs in families, so that explains that. And the role of environmental factors. So when they are exposed to certain chemical agents, they have more chance of developing endometriosis. Now, what are the types of endometriosis? There are 3 types, that is a superficial type, a deep infiltrating type, and the ovarian endometriosis. These are the types of endometriosis which are described. Superficial means it is above the peritoneum, remaining as such, and deep infiltrating type. So when you see the endometriotic tissue at least 5 millimeter depth from the peritoneal surface, you call it as a deep infiltrating type of an endometriosis. And you have an ovarian endometriosis also, when you find the endometriosis occurring in the ovaries. Okay. 78% of the diseases of pelvic seen in the pelvic sites, and only 12% are seen in the extra pelvic sites. Okay, so this is about the occurrence of the endometriosis, the sites of the occurrence of endometriosis. Now, what are the risk factors for developing endometriosis? The risk factors are early menarche as well as short cycles. Early menarche, people who have early menarche, that is less than 10 years or 12 years, and short cycles, that is once in every 20, 23 days or 25 days, they have the cycles, they tend to have more of a endometriosis. And increased menstrual frequency, that is same as the short cycles, as well as menstrual duration. So when the person is having bleeding for 7 to 8 days, those people are likely to have more of an endometriosis. Then delayed childbearing also, same thing might be playing a role. That is the loss of the menstrual blood into the through the tubes and getting more chance of endometrial. And so also the progesterone is not working there, producing any atrophy of such endometrial cells. So delayed childbearing also thought to be one of the risk factors for developing endometriosis. Then Mullerian duct anomalies. So when you have a non-communicating rudimentary uterus, and you have a that is not draining into the uterine cavity. So every time that endometrium is active and it is draining through the tubes into the peritoneal cavity. So Mullerian duct anomaly has more association with endometriosis. That is why cryptomenorrhea, when you have an imperforate hymen, it should be detected early and treated. Otherwise, it will lead to cryptomenorrhea, will lead to endometriosis later. Then people having low BMI have more risk of developing endometriosis. Then, as I said before, there is a role of genetic factors also. And people having atopy, that is asthma and allergy, also have an increased tendency for developing endometriosis. So what about this type of a disease? So it is progressive one in 30 to 60% of the patients. This disease is a progressive one. And minimal disease can regress spontaneously. There is very less chance that this disease can regress spontaneously. But in most of the patients, at least 30 to 60% of the patients, the disease is a progressive one. Now the next slide. Okay, the symptoms. What are the symptoms of the disease? So you should know what the symptoms are: severe dysmenorrhea, that is secondary dysmenorrhea. Earlier in menarche, she might not be having, but later towards 18, 20 years and all, she starts having dysmenorrhea. Okay. Then certain patients at 30, 35 years, till 30, 35 years, they will not be having this. And after that, again, dysmenorrhea starts. So it is a symptom which is seen earlier, a dysmenorrhea which was not there, now starting with it. Okay. So that is called as a secondary dysmenorrhea. So 60 to 80% of the patients have this type of a symptom. Then 30% of the patient presents with chronic pelvic pain. Okay, they have a lower abdominal, severe lower abdominal type of a pain, and more exacerbated during the time of menstruation. And after menstruation, it subsides, but the pain remains as such. She will be having some sort of a lower abdominal discomfort. Another thing is deep dyspareunia. Then 30 to 40% of the patients can also present with infertility. Okay, secondary dysmenorrhea, 30 to 40% infertility, deep dyspareunia. Then 20% of the patients can also present with menstrual disturbances like heavy menstrual bleeding, irregular type of, some patients will say, I have some brownish discharge for some days, then period starts, then again a brownish type of a discharge. Most of the days the bleeding is like this, and it subsides then again to start with a brownish discharge, fresh bleeding, and then again with a brownish discharge. So such a history you may find it 20% of the patients. Then certain patients will have polymenorrhea, that is shortened cycles also. Then pain in the lower back as well as the abdomen. Abdominal pain, back pain, etc. is also just like the chronic pelvic pain. This is also a symptom of endometriosis. Then cyclical perimenstrual discomfort. Then when you have extrapelvic endometriosis, you have bladder and not the pelvic, the pelvic endometriosis, you have the bladder and bowel irritation, that is cyclical in origin. So they have incomplete voiding feeling or increased frequency of micturition, incomplete voiding of the bowel, like that, bowel irritation. Such symptoms will be there perimenstrually. Then dyschizia, cyclical menorrhea, hemoptysis, pain and swelling at the site of the scar cyclically. So this occurs for extrapelvic endometriosis. So these are the main symptoms. So secondary dysmenorrhea, infertility, then deep dyspareunia, chronic pelvic pain, and menstrual disturbances. Then for other extrapelvic sites, you have other symptoms also. Then what are the signs? So when you go on with the exam, when you go on checking the patient, what do you find? When you do a bimanual pelvic examination, the patient presents with these symptoms and you suspect endometriosis. And when you do a bimanual pelvic examination, you find the uterus to be fixed or with a reduced mobility. And you have local tenderness. When you adenomyosis, you have a tender firm like uterus, and here the uterus is usually normal size or just bulky, but the uterine mobility is much restricted or it will be fixed, and you have local tenderness, especially when you palpate the fornices and the posterior pouch of Douglas, you have tenderness, and sometimes you can feel nodularity of the uterosacral ligaments. When you go a little bit laterally, you find through the posterior fornix, you find nodularity of the uterosacral ligaments. And if there is presence of ovarian endometriosis, you can find adnexal cyst or adnexal masses there. Okay. Then what are the differential diagnosis? So when the patient presents with such symptoms, dysmenorrhea, menstrual disturbances, chronic pelvic pain, infertility, etc., you have a suspicion of this, and you go on with a bimanual pelvic examination. Now, what are the other differential diagnoses? One important differential diagnosis is pelvic inflammatory disease. The patient can present the same way. Infertility, dysmenorrhea, same thing, menstrual disturbances, everything. So when you have the prominent bowel symptoms and all, you can, then the DD is irritable bowel syndrome, colitis, diverticulitis, etc. So when they present with some bowel symptoms predominantly. So when you have a cystic mass there, the other DD is an ovarian tumor. And the other thing is a pelvic congestion syndrome. That is when you have a chronic pelvic pain. Another DD for a chronic pelvic pain is a pelvic congestion syndrome. Okay. Then how to diagnose the endometriosis? Usually ultrasound is not very helpful for the diagnosis of the peritoneal endometriosis because you cannot find anything in the ultrasound by in detecting a peritoneal endometriosis. Okay. But when there is presence of ovarian endometriosis or the endometriosis cyst, you can find out this by the ground glass appearance of a cyst containing hemorrhage. When you have a cyst having hemorrhage, you have a ground glass appearance, and also you can suspect an ovarian endometrioma there when you have an ultrasound. So peritoneal endometriosis, you are not likely to, you cannot find out by an ultrasound scan. Now, what about the CA125? The CA125 is raised in endometriosis, but it is not specific for the diagnosis of endometriosis. It can be raised in any condition in which there is a peritoneal irritation, and you know that it is also increased in epithelial ovarian tumors, or when you have ascites, etc., etc. And when you have tuberculosis, anything, it's any inflammation of the peritoneum can produce a raised CA125, so it's not specific. Now, the CT and the MRI are helpful in the treatment of endometriosis. That is, you can know about the bowel involvement, and you can know which is closely adherent, whether the planes are maintained, or if one tissue is very closely adherent to the other. That is especially with the uterus as well as the sigmoid, etc. When it is closely adherent, it helps in the planning the surgery as well as the treatment. Now, how to diagnose this endometriosis? The gold standard is laparoscopy. So laparoscopy is the investigation which will help you to diagnose an endometriosis, and because you can directly visualize the tissues. Okay. So when you have suspicion, suppose you have endometriomas, and you can suspect this and diagnose this easily along with all those things. Okay. But the gold standard for the diagnosis is laparoscopy. Okay. Then what are the stages of endometriosis? To begin with, it appears as red or yellow vascular lesions. Then later on, it progresses to black powder burnt lesions. Then it progresses to fibrotic lesions, and lastly, it becomes white opacifications. So early stage of endometriosis, sometimes when you do a surgery for a patient with a, when you do a cesarean section, you can find certain yellowish blebs over the uterus, over the uterosacral ligaments, especially the posterior surface of uterus. And there is a thing like desidualization reaction, as well as when you find certain yellowish blebs over the uterosacral ligaments and the peritoneum. It's a early endometriosis. So it appears as yellow vascular lesions or reddish vascular lesions, then progresses to black powder burned lesions, then fibrotic lesions, black powder burned fibrotic lesions, and later on to white opacifications. Okay. Now, what are the laparoscopic findings? You can either find the powder gunshot burns or such lesions, or the black brown punctate lesions. Sometimes you can find nodules or the cysts containing old hemorrhage, and sometimes what you find is only the fibrosis. Okay, so these are the findings which helps us to suspect an endometriosis. Now, the staging of endometriosis. The American Society for Reproductive Medicine has scored the endometriosis. You can refer this by in the Google or this thing. I have not I have not included the slides, but taken the main points. Okay, so it takes into account the presence of endometriosis, whether it is superficial in origin or whether it is deep-seated in the peritoneum. That is either the superficial endometriosis or the deep endometriosis of the peritoneum of the ovary. Then it also scores 1, 4, 7, 14, such things are given. So another point is obliteration of the cul-de-sac, whether it's partial obliteration, full obliteration, etc. Then the presence of adhesions of the ovary as well as the tube. So these are the points which are taken into account, whether it is a superficial endometriosis or whether it is a deep endometriosis, whether it is involving the peritoneum or whether it is involving the ovary, whether there is obliteration of the cul-de-sac, then the alteration of the, then the adhesions, the presence of adhesions of the ovary, the presence of adhesions of the tube, etc. So scores up to 5, that is 1 to 5 is minimal disease, and 6 to 15 is mild disease, 16 to 40 is a moderate disease or a stage 3 endometriosis, and scores above 40 is severe disease. So depending upon the adhesions as well as the obliteration of the anatomy, whether it is deep or superficial seated, you give scores, and 1 to 5 is minimal disease, 6 to 15 is mild disease. Up to 40 is from 15 to 16 to 40 is a moderate disease, and above 40 is a severe disease. Now, what about the treatment? So our goal should be to maximize the medical treatment to avoid repeated surgeries. So as I said before, the endometriosis is a progressive one, and finally it leads to adhesions, fibrosis, etc. So all the organs will be adherent together. So when you the surgery is not that easy, and you are likely to injure especially the bowel during the surgical management of endometriosis. So repeated surgeries are very, very risky, leading the What if you have a bladder injury, ureteric injury, you have this sigmoid or rectal injury, she will be left with colostomy, ureteric implantation, all those things to suffer for the rest of the life. So we should maximize the medical treatment and avoid repeated surgeries in endometriosis. Now, how do we treat the patient? So when you think about the treatment plan, it depends upon the age of the patient as well as what is her presenting symptom. Now, is there any desire for future fertility? Is fertility her problem? Then it also depends upon the severity of the disease. There is the limit to which you can treat the disease. So it also depends upon the severity of the disease. The age, the presenting symptoms, the desire for future fertility, as well as the severity of the disease. An expectant management is not feasible in endometriosis because 32, you do not know, especially if it's only a superficial endometriosis, some may spontaneously regress, but 30 to 60% it progresses. So an expectant management is not feasible for an endometriotic patient. Patient with an endometriosis. Now, what is about the management? So I said the medical management, we should maximize it to avoid repeated surgeries. So the medical management consists of, she presents with severe dysmenorrhea. So that is one of the debilitating symptoms in endometriosis. So the secondary dysmenorrhea usually responds to begin with, you can try for mefenamic acid, etc. But later on, it responds only to higher, more potent agents like ketorolac, tramadol, etc. So that is for the analgesic management of that. Suppose they have dysmenorrhea only as the symptom, you can try for analgesics. Now, how to ready or how to make these implants non-active? You should give progesterone. That is, it can be administered as oral, parenteral, intrauterine, or as implants. That is also another medical modality. So first to begin with analgesics, then progesterone. The progesterone, medroxyprogesterone acetate, or your more androgenic progesterones like norepinephrine should be administered for these patients. Okay, I'll say in a little bit detail about the medical treatment in the next slide. Then GnRH analogs are, don't write GnRH analogs as the first treatment modality for endometriosis. Okay, it is medical management, analgesics first, then progesterones, then GnRH analogs. Even GnRH analogs comes later in the scene. Then you can try for danazol, that is an androgen, gestrinone, that is also the same group. Then LNG devices can be, levonorgestrel devices can be tried, aromatase inhibitors can be tried. Then there is also a surgical management for endometriosis, that is conservative surgery, like especially when you have infertility, you release the adhesions and you restore the tubal anatomy, that is release of the tubes as well as the ovaries. And the definitive surgical treatment is the removal of the uterus as well as the ovaries. Okay, so a little bit more about the medical management. Now, what about this progesterone? How does it act? So the progesterone, initially it produces decidualization, and later on it produces atrophy of the endometrial implants. So unlike the treatment for AUV, here you have to administer higher doses like medroxyprogesterone or your norepinephrine, 30 to 40 milligram per day should be administered for the treatment of endometriosis. Then I said other routes you can, that is norepinephrine acetate 5 milligram TID, that is 15 to 20. Actually, 20 to 30, certain patients respond to 20 to 30 milligram per day. Then injection DMPA, that is depot medroxyprogesterone acetate, can be given as 150 milligram every 3 months. You can give this injection instead of taking daily dose. Or Dynogest, you can give 2 milligram per day is the dose. Okay. So norethistolone is available as 5 milligram tablets and 5 milligram TID. So it's only 15 milligrams. Certain patients respond to 20 to 30 milligram per day only. So it's 222. They respond as 222. That is 5 milligram tablets as 222 is given. So when you administer this as a continuous dose, you have amenorrhea setting in and more chance of the endometrial implants subside. Okay. And then there is also a role of oral contraceptive pills. That is, a low dose oral contraceptive pills can also be given for the treatment of endometriosis. And how does this act? This acts by producing an ovarian suppression, and a continuous administration of OCP produces amenorrhea. So there is endogenous FSH, LH, everything is lost. So there is total hormone is also less. So that also leads to the suppression of the endometrial implants. But because of the presence of estrogen, there is chance that it may not subside also. But most of the patients respond even to OC pills also. Then what about other things? Danazol, androgen. So that produces ovarian suppression and regression. So the dose is 100 to 200 milligrams per day, and 6 to 9 months therapy is advised for all these medical managements, whether it is progesterone, danazol, NPA, this thing, DMPA, etc. All these things are given for a total of 6 to 9 months. Now, what about the disadvantages of danazol? Because it is androgenic, it has a bad effect on the lipid profile and also liver dysfunction. So, patients having such problems cannot be given for danazol for a long period. Okay, it will produce liver dysfunction and all. Then the GnRH analog, that is a leuprolide. It is given as a dose of 3.75 milligram subcutaneously every 4 weeks, and you can give 6 months therapy, and it also produces ovarian suppression, but you have to give add-back therapy. Estrogen progesterone combination should be given along with this low dose, otherwise it will produce profound menopausal-like symptoms. Okay. And also with prolonged administration of GnRH, you have bone loss and there is more chance of fractures occurring, etc. So should be supplemented with calcium also. Patients taking long-term heparin, GnRH, etc., they have to be supplemented with calcium. Here, because there is a ovarian suppression and estrogen deficiency, that reduces less of a bone density and more chance of fractures. Okay, so add-back therapy should be given if you are planning for a GnRH therapy. Then this levonorgestrel can also be given as intrauterine devices. That is the Marina. It contains 52 milligram of the drug, and it releases 20 microgram each day. But the problem with the Marina is an irregular type of a bleeding associated with its use. So the therapies include, the first one is the analgesic therapy. To start with, it may respond to mefenamic acid. Later on, you may land up in some higher potent analgesics like ketorolac or tramadol. Then you can give progesterone, the low dose OC pills, and the different ways of administering the progesterone. Then you have the danazol. Then you have the GnRH analog. And you can also say the levonorgestrel, that is, the progesterone can be administered as intrauterine devices and as well as monthly depots. Okay, so these are the different modalities of treatment, the low dose OC pills. These are the different modalities of treatment for endometriosis. So when you are asked about the medical management or the treatment of endometriosis, you have to discuss all these things. Okay, tell about the dosages also. Now, what about endometriosis and infertility? Why infertility is seen in endometriosis? It is the first and foremost reason. It is due to the disturbed tubal anatomy. That is because of the adhesions. The tubal anatomy is altered. There will be kinking and more chance of ectopic gestation formation also, as well as infertility in endometriosis. Then there is also abnormal folliculogenesis, anovulation. You have frequent cycles occurring. So you don't have a time for the the progestational phase and increased. So the immature follicles, all those things develop, and there is enough estrogen there, but not adequate progesterone there. So abnormal folliculogenesis, and certain patients have anovulation also. Then there is a condition called as luteal phase defect. That is, I said progesterone deficiency is there. So luteal phase defect is there. That is also preventing the implantation from happening. So you have infertility there. Then there is a condition called as luteinized unruptured follicle. That also leads to this infertility. So it is not only the disturbed tubal anatomy, there is abnormal folliculogenesis, there is anovulation, there is luteal phase defects, there is a condition called as luteinized unruptured follicle, LPD, or the luteinized unruptured follicle. And there is also reduced endometrial receptivity. So the endometrium is not prepared because of inadequate desubitalization. Okay. Then another factor is a reduced sperm survival, as well as there is, because of the inflammatory factors, there is reduced sperm survival because of the altered immunity. There is phagocytosis of the sperm or the fertilized egg, and there is also intraperitoneal inflammation. So inflammatory factors also produce this type of infertility. Then these are the causes for infertility in case of endometriosis. Okay. Then what about endometriosis and malignancy? Is there a chance that if endometriosis occurs, is there a chance that it can change into malignancy? So the chances are very, very less. It's 0.7 to 1% of the patients, especially long-term endometriosis, untreated endometriosis, they can develop malignancy. And the good thing is that whenever a malignancy develops, it's usually a low-grade type of an ovarian malignancy. In 70% of the cases, the pathological variety is endometrioid carcinoma, and clear cell, not of a very good prognosis. Clear cell is seen in 14% of the cases. Usually it's a low-grade ovarian malignancy which is developing in endometriosis. So that's all about endometriosis. It's a very important topic, and you have to know. Sometimes you'll be asked questions like, what is the pathogenesis? Tell about the pathogenesis of endometriosis. Then you have to say about the all the theories behind the formation of endometriosis. Sometimes that alone will be asked as one question. So you have to say about all those things. Then how it is classified, it's either superficial, deep, or ovarian endometriosis. Then what are the presenting symptoms, what are the signs, then how do you diagnose, what are the diagnostic modalities, and among them the laparoscopy is the best or the gold standard, and what are the laparoscopic findings of endometriosis. And then the advantage of laparoscopy is that not only helps in the diagnosis, as well as it also helps in the treatment of endometriosis. Okay. So with the treatment plan only, you do a laparoscopy. Then what about the management of endometriosis? You have a medical management because you cannot have an expectant management. Only a few cases will subside. Most of them progress to a progressive disease. So you have to have a medical management for the endometriosis, and the medical management depends. The management depends upon the age, the wish of the patient to have a future fertility, then the parity of the patient, then the severity of the disease also is very, very important. Okay. Then the different modalities of management. You have the medical management as well as the surgical management, the conservative surgery as well as the definitive surgery. And when you have the medical management, you have to say about the drugs, say about progesterone, OC pills, Danazol, etc., followed by GnRH analogs, and so on. Okay. Then say about the surgical management also. So the definitive surgery is TAH with DSO, and the conservative surgery is altering the tubal anatomy. So sometimes you may have to go in for bilateral self-injectomy and IVF treatment if its future fertility is required. In certain cases of endometriosis. Okay. Then what is the reason for infertility in endometriosis and the risk of malignancy in endometriosis? That's all. So shall we conclude? Any doubts? Hello? Are there any doubts?
No, ma'am.
No. Then we can conclude the session. How do you give the attendance? It's directly sent or through the this thing, or you send it to me? How do you send this session attendance?
She will send it to you, ma'am.
Attendance എങ്ങനെ അയക്കാതെ പിന്നെ ഷാജി അതോ പിന്നെ നിങ്ങളിങ്ങനെ ഡിപ്പാർട്ട്മെന്റിലേക്ക് സെൻഡ് ചെയ്യാണോ?
Ma'am, ഡിപ്പാർട്ട്മെന്റിലേക്ക് സെൻഡ് ചെയ്യാം.
Send ചെയ്യാണ്. Then you send my phone also. Okay.
Okay, ma'am.
If there are no doubts, we can conclude the session because you might be having other sessions also. Okay. Any doubts? At least learn these slides, okay? Because it's an important topic for your exam. Write this much when you have a essay asked about this. Shall I leave the meeting?
Okay, ma'am. Thank you, ma'am.
Okay. Okay. Thank you.